So with that background, let's talk a little bit about CIDP in patients with diabetes. Now we know that CIDP is a rather rare condition, and in different studies the prevalence has been said to range from about 3 to 9 per 100,000. So there's not a lot of people wandering around in the community with CIDP. It's a condition that causes significant morbidity due to progressive weakness. There's usually some associated sensory loss, but in primary CIDP, sensory loss tends to be relatively minor, and pain tends to be a minor effect. It's a demyelinating disorder, but there's always associated axonal degeneration, and in fact the treatment must be started early because we need to start treatment before too much axonal degeneration has supervened, because if there is axonal degeneration, there will be incomplete and slow recovery. And in fact, a study out of the Netherlands said that if you haven't started treatment of a CIDP patient within 2 years of diagnosis, they're probably not going to respond satisfactorily to therapy. We'll come back to that point when we talk about the diabetic situation specifically. Now, people in India don't need me to tell you this. Diabetes is very common. The prevalence in India is about 9%, at least it was in 2017, and I suspect it's gone up even higher since then. It's actually particularly prevalent in southern India. I didn't realize this, but in urban populations in southern India, the prevalence is about 20%. 1 in 5 people in the urban populations of southern India have diabetes. And in fact, if you look at hospital-based prevalence studies, so these are people who are admitted to the hospital, so not necessarily characteristic of the community as a whole, but figures as high as 33%, 1 in 3 patients has been found to be diabetic. Now these numbers have led to the statement that diabetes is a 21st century epidemic, and it probably is not too much of an exaggeration. The prevalence in the United States is about the same as it is in all of India, that is about 9%. But we have a terrible problem with obesity and terrible diets in the US. And worldwide, the prevalence is increasing. And when I was at medical school, the trick question was always, what is the commonest cause of neuropathy in the world? And we'd all scratch our heads and say, well, diabetes, maybe alcohol. But back in the 1960s, when I was at medical school, the answer was leprosy. But that's not true anymore. First of all, because we can treat leprosy, and so we see less problems with leprosy, and also because diabetes has shot up. So with that frequency of diabetes, it's not perhaps surprising that we see concurrence of diabetic neuropathy or diabetes and CIDP not infrequently. And up until the 90s, it was often said that diabetics were at an increased risk of developing CIDP compared to non-diabetic persons. And so that was studied in 2 ways. You can look at the prevalence of CIDP in a population of diabetics, or you can look at the prevalence of diabetes in a population of patients with CIDP. And that has been done in 2 studies, one from Olmsted County in Minnesota, where the Mayo Clinic group showed that the prevalence of CIDP in population of diabetics in Olmsted County was exactly the same, admittedly the upper part of that range of normal prevalence for other populations. And the Italians did the opposite. They said, let's have a look at our cohort of CIDP patients and see how many of them are diabetic. And again, the number was exactly what you would have expected from a non-CIDP population getting diabetes. So the current thinking is that the concurrence of these 2 disorders is probably no more than chance. And again, the Mayo Clinic study did acknowledge the possibility that there might be a tiny effect size because their prevalence rate was right around the upper limit of what had been reported in other studies. And we're relatively frequently called on to determine whether neuropathy in a diabetic could have a treatable basis. And I've heard people say, well, why don't you just treat them and see? But I think that's not without risk. First of all, if we're going to give them steroids, the commonest treatment used for the treatment of CIDP in most of the world. In the US, we like to do things the most expensive way we possibly can, so we tend to use a lot more IVIG there. But both steroids and IVIG have significant risks in patients with diabetes. Steroids makes the glycemic control worse. IVIG, the thrombotic risks of IVIG are much, much greater in diabetics than they are in the general population. If we're going to give patients chronic immunosuppressive therapy like azathioprine or methotrexate, well, diabetes are already at an increased risk of infections, and so we're going to exacerbate that risk by the use of these drugs. And quite apart from risk, IVIG is cripplingly expensive. So I think that we shouldn't just blithely give a trial of therapy and see what happens. On the other side of the coin, we don't want to miss a treatable neuropathy in patients with diabetes, because diabetic neuropathy can be a significantly disabling condition. So we want to make sure that there's not something there that we can treat. So you look at lists like this, and it seems very simple. You know, CIDP is subacute, it's predominantly motor, it's global areflexia. You can read all the features of CIDP on the list here, and you match them with the features of diabetic neuropathy, and you'd say, why is there a problem here? This is easy. But in fact, it's not easy, or at least sometimes it's not easy. There are sufficient numbers of atypical cases which make it very difficult to be certain. And importantly, the degree of axonal degeneration you get in CIDP in a diabetic is much more than you get in CIDP in a non-diabetic. So when you get all that axonal degeneration, it can be very difficult to identify the underlying primary pathology of demyelination. And similarly, patients with diabetes, particularly diabetics who also have renal failure, can get very significant conduction slowing into the so-called demyelinating range. And so you may think this looks demyelinating, yet it's just due to the diabetes. And while CIDP in non-diabetics is a very predominantly motor disorder, in diabetics with CIDP they get a great deal more sensory involvement, probably because of concomitant diabetic neuropathy. And so it's not as easy as it seems by looking at lists like I put up there. And so I always like to present some cases to illustrate my points. And this was a patient I saw actually at St. John's quite recently. She was 59, she had type 2 diabetes of about 15 years duration. And she'd been on a long car trip, and when she got out of the car, suddenly noticed she had a right foot drop. That's what brought her to medical attention. But when she came in to see us, she told us that she'd had some numbness and some vague tingling sensations in her feet that had begun about 2 months before she developed this foot drop and had ascended approximately to the mid-calf level. And about the same time, she'd noticed mild weakness of foot dorsiflexion bilaterally. Not just on the side that subsequently developed a severe drop, but bilateral weakness of foot dorsiflexion, and some weakness also in her intrinsic hand muscles. She'd also noticed that her balance had deteriorated. I've learned a new science since I've been in India. It's called the Washbasin Side. And it's when people close their eyes and lean over the wash basin to wash their face, and they pitch forward into the wash basin. We ask, do you fall over when you close your eyes in the shower? But regardless, balance that is worse in the dark is indicative of a proprioceptive disorder of sensory ataxia. And up until 2 months prior to her onset of sudden onset of foot drop, she'd not had symptoms of neuropathy. Her diabetes was certainly not optimally controlled, but it wasn't too bad. Her glycated hemoglobin level was only 8.3, and she had normal renal function. An examination showed symmetrical weakness in the hands, affecting both median and ulnar territories, and she had mild atrophy of the FDI bilaterally. A more proximal upper extremity strength was normal. There was clear weakness of hip flexion bilaterally and also of knee flexion, but knee extension was normal. On the right side, the affected side, she had MRC grade 1 strength. You could see a flicker of muscle contraction, but insufficient to displace the joint. But she also had clear-cut but mild weakness on the contralateral side. And there was no lower limb atrophy. The sensory exam confirmed what she told us, that there was a cutaneous sensory loss up to about the mid-calf, and vibration sense was absent at the hallux bilaterally and present only for about 4 seconds at the medial malleolus. Romberg's sign wasn't truly positive. By definition, she didn't stab or fall, but she did show what I would regard as pathological swaying. And importantly, she had global areflexia. I think if you're looking for one physical finding that should make you think of CIDP, it's areflexia in muscles that have relatively normal strength. So I told you that her proximal arm strength was normal, biceps and tricep strength was normal, and yet she had no reflexes. So this was a patient who was brought to our attention because of the sudden onset of a foot drop. And she'd had these antecedent neuropathic symptoms dating back about 2 months. And she had this important finding of global areflexia along with the proximal and distal weakness. So is this diabetic neuropathy, or is it CIDP in a patient with diabetes? Well, what I tell the residents is that if you don't say that the first test you do in a patient with neuropathy is nerve conduction studies, you're fired. It is your first step in every patient that comes to see you with neuropathy. And so we did nerve conduction studies on her, and here you see her right perineal nerve completely absent response. Not surprisingly, she only had a flicker of muscle movement there. The left perineal was slightly reduced amplitude, but really not too bad. But her conduction speed was in the mid-30s. I'm not convinced about that. This makes me suspect the possibility of a demyelinating disorder, but from that alone, I would not be convinced. We look at the tibial. Well, the conduction here is even slower, 26 meters per second on this side, but the amplitudes are terribly low. So again, I'm not completely convinced, and the opposite side, the same kind of thing. So it's sort of difficult, at least, in the legs. But the arms make life a little bit easier for us. So here is the left median nerve. Remember, it's mildly weak. The amplitude is quite reduced, and the duration of this distal compound muscle action potential is nearly 9 milliseconds. That should not be greater than 6 milliseconds. So that's substantially prolonged. Here in the opposite median, you have a segmental amplitude change between wrist and elbow with a drop of almost 50% in that amplitude, which is never normal, but look at how low the amplitudes are. So again, you have to be cautious about interpreting that. Distal motor latencies are markedly prolonged at least on the right, and a little bit prolonged on the left. The ulna, not really very helpful. She's got slightly reduced amplitudes. She's got slight conduction slowing. And she does not have abnormal prolongation of the distal CMAP amplitude. So you look at any one nerve, you may be unconvinced, but when you put the whole pattern together, she in fact has variably reduced CMAP amplitudes, and she's got this patchy motor conduction slowing, some very long distal motor latencies, some patches of very slow conduction velocity. She's got the dispersion of this distal CMAP amplitude. I didn't show, but she had absent F waves throughout. And she had this segmental amplitude decrement that I would be cautious about interpreting with a very low amplitude like that. But you add it all up, and probably it is more likely to be a demyelinating disorder. So I felt that she probably did have CIDP. There was probably a background of a distal symmetric neuropathy. And I don't know what this right perineal nerve, it could be an entrapment from the long car ride, or it could have been a diabetic vasculitic neuropathy affecting the perineal nerve. We're not really very sure about that. We would say that the right foot drop was very unlikely to be due to CIDP because it came on too rapidly. And so she had relatively mild diabetes. She had no prior symptoms of neuropathy. Her condition was evolving subacutely. It was predominantly motor, and she had proximal and distal weakness and global areflexia, all features much more suggestive of CIDP. And in fact, she fulfilled 3 neurophysiological criteria for demyelination. And if you accept the conduction block, I've said I question it myself, but if you did accept a conduction block, she has 4 electrophysiological criteria for demyelination. And one study by Dr. Uncini out of Italy found that only 4% of patients with diabetic neuropathy met 2 criteria, 0 met 3 criteria, and certainly none met 4 criteria. So in fact, this patient has a predominantly demyelinating disorder. Now, we often say that the CSF protein in a diabetic may be up to 100, and if it's above 100, it's more likely to be CIDP. She did not make my life easy there. She was 90, so it could have been her diabetes, but her diabetes is pretty mild. But I felt this was supportive of a diagnosis of CIDP. Now, we didn't do a nerve biopsy just because we chose not to, but Uncini's group had also shown that nerve biopsy was unreliable in distinguishing between CIDP and diabetic neuropathy. Both had signs of demyelination, both had axon loss, both had evidence of inflammation. So he found that when those biopsies were read blind, they could not reliably distinguish between the 2 conditions. So what other things should I have thought of? Could this be a diabetic vasculitis? So some of you may have heard me talk about this condition of diabetic vasculitis that results in an acutely evolving disorder. The classic one is diabetic amyotrophy, but you can also get mononeuropathy multiplex, you can get diabetic truncal neuropathies, and probably the diabetic cranial neuropathies are part of this spectrum. So the onset of the acute perineal neuropathy at least raises this possibility, but in fact her proximal weakness was symmetrical. It was not asymmetrical. She had no constitutional symptoms specifically. She'd had no weight loss, and most of your diabetic amyotrophy patients will have that. And she had the global areflexia, which you can certainly lose reflexes in the affected area in patients with diabetic amyotrophy, but not global areflexia. And the electrophysiological features would make that an untenable diagnosis. And this is another one we get asked about. Could this just be a distal polyneuropathy with entrapment neuropathy superimposed? It's not at all uncommon to get bilateral carpal tunnel, perhaps even bilateral carpal tunnel and an ulnar, and even a perineal thrown in. So that's something that we would need to think about. Again, the global areflexia argues against that. She had the proximal lower limb weakness that I mentioned, and this point here that she had this marked dispersion of the distal CMAP, and that does not occur in carpal tunnel syndrome. You can get marked prolongation of the distal motor latency, but you do not get dispersion of the distal CMAP. So we haven't proven it in this patient, but I'm strongly leaning towards this being CIDP. And why haven't I proved it? Why haven't I treated her to see what would happen? She refused. So she has gone home and has declined treatment, but has agreed to come back for further assessment. So maybe we'll get an answer, but at the moment we're uncertain. So what about the first challenge of CIDP in a diabetic is making the diagnosis. The second challenge is treatment. And we know that treatment response is less assured in patients with diabetes who get CIDP because there's more axonal degeneration. And so therefore it's critically important to recognize and treat early. And although there's been no formal studies done, there's no reason to expect that the response to treatment in a diabetic would be any different. And in fact, the treatment modality is primarily determined by the wants of the patient and the preferences of the prescriber. And I've said that in the US, the vast majority of these patients are treated with IVIG. Partly that's personal greed, because neurologists have their own infusion center and they can feather their own nests if they get the patient in for infusions. Partly it's because American patients are very reluctant to tolerate adverse effects from steroids. But regardless, I've used steroids in diabetics without problems. In New Zealand, I treat all my CIDP patients regardless of whether they have diabetes or not with steroids. And in fact, what we have been doing now for about almost 20 years is use pulse steroid regimens. So instead of giving daily steroids with the attendant risks of that, we give a large dose of steroids once a week, 500 milligrams of methylprednisolone. We give it by mouth, which is very simple, safe, easy to do. We just give that once a week. So you have hyperglycemia on one day a week, but you don't get chronic hyperglycemia. It's well tolerated, it's effective, and that's what we do routinely. In fact, these pulse steroid regimens have very, very much less in the way of adverse effects. We don't see weight gain, we don't see skin changes, we don't see the moon face that you see with the daily steroid effects. And so we've routinely gone to pulse steroid regimens. IVIG can be used in diabetics, but the risk is greater. As I've already said, these patients can get thrombotic complications. The diabetics are much more likely to get a renal impairment with IVIG, so I hesitate to use IVIG in diabetics. A therapeutic plasma exchange is a perfectly effective and suitable alternative, but it's cumbersome. It's hard to do. You've got to get the patient into a treatment center, and it's okay for the short term, but not for long term. And in fact, if we practice evidence-based medicine, there's no evidence that azathioprine or methotrexate or mycophenolate is effective in the treatment of CIDP. And we all believe that they are, but what we believe, that's neuro-religion, not neuroscience. And if we follow evidence-based medicine, there's no evidence that these drugs work. Rituximab is a treatment that I've been interested in for quite a long time. And we are in the process of writing up a series of patients who have treated, CIDP patients who have treated with rituximab with extremely good results. Now, we do have to acknowledge that the majority of patients do not respond. We don't yet know what it is that predicts response to treatment. There's some suggestion that certain antibody profiles are more likely to respond, like neurofascin 155 or contactin, but at the moment we're not certain. At the moment we don't know which patients will respond to treatment. But because the treatment in India is so inexpensive, and because it has no additional risks in a diabetic, it's an attractive option. And in fact, very low doses may be effective. There's evidence that doses as low as 100 milligrams may be effective. 500 milligrams cost about 15,000 rupees. So 100 milligrams would cost about 300 rupees, 3,000 rupees. So it's an affordable treatment. It's not like the US where it costs $25,000 a year to treat a patient with rituximab. And so it's at least something that you might want to think about in your diabetic patients. So to summarize this part of the talk, if you have a diabetic who develops an subacutely evolving neuropathy that is predominantly motor in its manifestations, which has proximal weakness, in which there is global areflexia, in which there are multiple demyelinating features on the nerve conduction studies, particularly, but not necessarily, if the protein is greater than 100, you ought to think about CIDP. And we're doing more and more MR neurography to look at the nerves, and I think that's going to be an added way of distinguishing between diabetic neuropathy and CIDP.